Good day, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentation. Today's topic is measles, and our invited speaker is Dr. Erik Berg. We're delighted to welcome Dr. Berg, a medical consultant with the Epidemiology and Immunization Services branch of our County Health and Human Services Agency, to share his expertise on this re-emerging, highly infectious disease. Dr. Berg's talk today is very timely. Just 1 week ago, hundreds of people were potentially exposed to measles at UC Davis Medical Center. And just yesterday, the CDC issued a health advisory to inform clinicians and public health officials of an increase in global and US measles cases and to provide guidance on measles prevention. Measles is highly contagious. One person infected with measles can infect 9 out of 10 unvaccinated individuals with whom they come into close contact, one of the most contagious infectious diseases. And we're very fortunate to have Dr. Berg as our speaker today. He's a practicing emergency physician and a U.S. Army reservist who earned his bachelor's degree at Harvard College and completed medical school and emergency residency at USC. Welcome, and thank you for joining us today. Over to you, Erik.
Thanks, Christy. Good morning, everybody. Thanks a lot for having me. Let me share my screen here. All right. Are people seeing my screen?
We were.
Coming on now. Good. Looks good.
Okay. Great. As Christy mentioned, yeah, very timely. As most of you probably know, we in San Diego County had our first case of measles last month. That was the first case we had seen in the county since 2019. So there is, and with all of the increased measles activity nationally as well as internationally, we're expecting that this won't be our only case. With that, I'll get started. So just a quick recent history of measles. So it was considered eliminated in the U.S. in 2000. Since then, the nationwide we see cases, not too many. So it does come in cycles, but really all of these cases are originating from international travel. And in the States, our high national MMR coverage does prevent more widespread transmission, but we do see these pockets of under-vaccinated communities that still presents a persistent risk for cases and outbreaks. So this graph is from the CDC. Last year in 2023, we had 58 cases nationwide, and so far in 2024, we have 58 cases as well. So definitely some increased measles activity is expected throughout this year. So just a quick clinical overview. So incubation period for measles is 1 to 2 weeks. So 1 to 2 weeks after exposure is typically when symptoms start. Day 1 is going to be non-specific URI type symptoms, so fever, cough, coryza. Typically day 2 you get the Koplik spots, but not always. And then from day 3 to day 5, you get the rash that classically starts on the face and then descends. And then just a reminder, since many of us have never seen a measles case, but and really it without having seen it, without it being kind of top of mind for a long time, sometimes we forget about the complications that come from measles or can come from measles. So really the high hospitalization rate, children are particularly susceptible to some of the sequelae, so pneumonia, encephalitis, and the death rate is relatively low, but really the pneumonia and encephalitis complications for kids, and then and complications for pregnant women as well. So I'm going to go through this kind of quickly. It's kind of an overview of the public health response here for our case that was identified in February. So this was a 12-month-old unvaccinated child who recently returned from international travel. During the child's infectious period, contacts were exposed at 2 healthcare facilities and 2 community sites. Fortunately, there were no secondary cases identified throughout the incubation period, but we'll kind of go through what happened just with that one case. So Rades contacted us on the 1st of February for a suspected measles case, sent a specimen, a PCR, a PCR specimen to the San Diego Public Health Lab, and came back positive on that same evening. As we ran through our case investigation, we learned the child returned to San Diego on the 22nd. Prodromal symptoms started, followed by a rash onset of the 31st. So that gave us our infectious period of rash onset -4 to +4. So from the 21st to the 4th. And during that infectious period, like I said, the case visited 2 healthcare facilities. So one pediatrics clinic, and then the children's ED, and then 2 community sites, a restaurant as well as a park. So in terms of our response, really the first priority is to identify contacts. And so fortunately, the healthcare facilities were able to generate a list of patients and staff. And we can talk more about it if you'd like, but we considered everybody in the ED at that time to be exposed prior to when the child was placed in negative pressure isolation. And that has a little bit to do with the ventilation systems. But again, we can get more into details if you'd like. And then for the community exposures, we used a variety of media to get out the word to try to identify contacts. So using traditional media, social media. And then really once we identify contacts, we need to triage the high-risk contacts who are going to need post-exposure prophylaxis. And really this is kind of the crux of the issue and how time sensitive it is in terms of a public health response. Getting the PEP window is really short. So really the MMR vaccine needs to be in an arm in 72 hours after exposure. Do have a little bit more time, so 7 days for immunoglobulin, and really the IG is reserved for patients that are at more severe or higher risk for severe outcomes. So pregnant women, severely immunocompromised, and then very young infants. But MMR is really the go-to PEP for most contacts, and that window is very short. So through our investigation, we identified almost 300 contacts. Fortunately, 250 of those contacts met criteria for immunity. We did have to quarantine 45 of those contacts. Included in those 45 quarantined cases, there were healthcare workers. So just kind of highlights the importance of the documentation requirements for measles immunity for healthcare workers. It's stricter than for the general public. So we did run into at the pediatric clinic a lack of measles immunity documentation that unfortunately we had to quarantine some of those healthcare workers until we were able to draw some titers and release them. And then we had to exclude 40 contacts from high-risk work, basically childcare facilities. Really, our post-exposure prophylaxis work, I was really proud of. We partnered with Radies and Champions for Health to get PEP to folks that needed it. So we administered 28 PEP doses, including 13 MMR and 15 IG. And so kind of at a high level, some of the key lessons that we learned, so specifically for healthcare facilities, pre-planning on how to deal with, how to identify and then isolate any suspected measles cases. That really does, any delay in identification or isolation of a suspected case really exposes many more people, and particularly in EDs and other healthcare facilities. So kind of pre-planning on how the workflow would go for a suspected measles case can really pay dividends. Our partnership for PEP administration was huge. This scenario, we had about 300 contacts. We can imagine scenarios in the future excuse me, where there'll be many more contacts. And so being able to partner with healthcare facilities to get exposed people the PEP that they need is really important. And then really prophylaxis. So I think one of the key lessons that we learned was that the CDC recommendations for MMR vaccine are not really there's not widespread adoption to them in the community, and this isn't just a San Diego issue. This is nationwide, and this was kind of the topic of the CDC alert that Dr. Koenig talked about. And really, any international traveler 6 months of age or older should be getting the MMR. So MMR, typically you give the first dose is at 1 year old, but if international traveling is happening, that MMR dose should be given early at 6 months. And then, so those are kind of our broad key lessons. I think for base hospitals, the key recommendation, again, is just early identification and then immediate isolation. And this was another alert that came from the states, from California Department of Public Health. And it kind of highlighted the take-home messages here. So delays in identifying and isolating measles cases in healthcare settings can result in exposures to hundreds of additional contacts. And then really from CDPH, the recommendations for a suspicion of measles, it's going to be the fever, rash, and then international travel. I would include a history of MMR vaccine. So really being able to get that travel history, and then if possible, a vaccine history can really help. Reason why I would recommend including the vaccination history is because 1 dose of MMR is going to be effective in preventing measles at 93%. 2 doses will be 97%, but even that 1 dose really reduces risk for measles cases. So I think that's it for me. Happy to answer any questions.
Thank you very much for that excellent overview. Could you comment if our field EMS clinicians see a case that might be measles, about what type of PPE they should work, and particularly about airborne transmission?
Yeah, it's a good question. I think the source control is going to be really important. So that may be tough if we're dealing with a suspected measles case in an infant, but I would source control, and then an N95 for on the rig or in a healthcare facility for anybody that's around a suspected case.
Thank you. So N95 or equivalent respiratory protection. Dr. Sloan, you have a question or comment?
Yeah, thanks. Kind of a self-centered question. Last time I had my titers checked was when I enrolled in medical school. Is it sort of a, yes, you had them, and so that the lifelong immunity comes from it, or is there a period in which people should be making sure they're still immune?
It's a good question. We do consider people that have been fully vaccinated and that or have a positive titer to be lifelong immune. That being said, there is talk now that we do see waning immunity in some cases, but really kind of as of now, we do consider a positive titer to be lifelong immune.
Cool, thanks.
Thank you. I'm not seeing any more hands raised or questions in the chat. Does anybody have any other questions or comments? Dr. Berg, would you like to comment on vaccine hesitancy, in part secondary to the COVID pandemic and the newity, if you will, of the vaccines, and how this is affecting childhood vaccination status in our country in light of something like measles, which is so contagious in vulnerable populations?
Yeah, it's a tough topic. I mean, we are seeing vaccine hesitancy across the board, whether it's hesitancy or whether it's a gap in healthcare access during the COVID pandemic and having to catch up from that period of time. We are seeing a small dip in vaccine coverage in children in the county for really across the board, but MMR included. That being said, we still have a very high vaccine MMR coverage rate here, higher than other places in California, but certainly something that we're tracking and really trying to develop messaging that's going to be effective for MMR and other really necessary vaccines.
Thank you. And Dr. D'Onofrio points out there was vaccine hesitancy prior to COVID. Of course, COVID just exacerbated it. And I think the point you just made, Dr. Berg, takes me back to your first point, which is the importance of the travel history, because many of these are going to be international travelers. So if you have somebody with a rash who's had international travel, then your radar should be up potentially for measles, because unfortunately we are seeing it again in modern times.
Yeah, and one last comment on that. So really any international travel, I mean, there's definitely a spectrum of risk. There are, countries that have higher that have current measles outbreaks, but really we're considering any international travel to be a risk factor, just because going through an airport, you're going to be exposed to folks from all over the place. So and there are outbreaks on several continents currently, so it's really any international travel.
Yes, indeed. And congratulations to your team on the rapid contact tracing and prevention of secondary infection. I know that is a huge deal, and we appreciate your work on that.
Thank you.
All right, I don't see any other questions in the chat or hands raised, so we will thank Dr. Berg very much for this helpful presentation and sign off at this time. Thanks, everyone.